You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for January 26, 2024. This week, left atrial appendage occlusion, more evidence that stable coronary disease is stable, cardiac resynchronization therapy, benefit over the long run, and AF monitoring after stroke. The first topic is left atrial appendage occlusion. And you all, it's not my fault. Please blame the European Heart Journal. I am just a messenger here. Last week, authors from Athens, Greece, first author Athanasios Samaras, published a meta-analysis of 48 studies, both RCTs and observational studies, looking at the incidence and prognosis of residual leaks following percutaneous left atrial appendage occlusion. First, some background. The idea of appendage occlusion is that if you completely occlude the left atrial appendage, clots cannot form there, and you reduce a substantial nidus for cerebral embolism and stroke. The added benefit, proponents say, is that after occlusion, the device endothelializes, and then you can stop oral anticoagulation, thereby reducing bleeding risk. And I have to admit, this is a great story, and I'm sure it's easy to explain to patients. A major problem, though, is that our human left atrial appendage come in different shapes and sizes, and it's hard to get complete closure. What's more, and this is a whopper of a barrier, if the device leaves a little leak, blood can more easily pool inside there and clot. And surgical data on appendage closure has shown that incomplete closure is a serious risk of stroke. Now, many studies have documented peri-device leaks after percutaneous closure. The nice thing about the current paper, the meta-analysis, is that it brings together and it sums up the incidence and prognosis of these leaks on many of these papers, 48 papers. So let's do the results. All but 4 of the 48 included studies were observational. The total number of patients studied was nearly 62,000. The main finding was the most sobering. Peri-device leaks, as assessed by transesophageal echo, TEE, was found in 26% of patients, 1 in 4. Wow. Now, 2 notes on this. A, this incident stems from centers who actually report things in the academic literatures, and you might expect that these centers are better at implantation than, say, lower volume centers that don't report data. And B, this incidence is by the standard transesophageal echo. But the authors of the meta-analysis also report the incidence of peri-device leaks by CT scanning, which is a more sensitive technique. Here, as I have reported recently on TWIC, peri-device leaks were noted in 57% of patients. Now, I find this extremely sobering, but proponents will argue that prognostic data is based on TEE, and we don't know what finding patency or peri-device leaks by CT scan, what that means. The authors broke down the size of the leaks. Any leak occurred in 26%, peri-device leaks greater than 1 millimeter occurred in 15%, peri-device leaks greater than 3 millimeters was seen in 10%, and I think that's an important number because of what I will tell you now. Now, the next step was doing correlation between leaks and thromboembolism. So any leak compared against no leak associated with a pooled odds ratio of 2, with confidence intervals going from 1.5 to 2.7. Any peri-device leak also associated with a 12% higher rate of major bleeding, and also the confidence intervals here did not include 1.0. The authors also found a graded association between the size of the leak on TEE and the risk of thromboembolism. So for any peri-device leak of greater than 0, 1, or 3 and greater than 5 millimeters, the pooled odds ratios for thromboembolism were 1.82, 2.1, 4.1, and 4.4, respectively. And that was compared with either no peri-device leak or peri-device leak smaller than each cutoff. Now, that's a lot of numbers, so let's emphasize that for a peri-device leak of only 3 millimeters, which occurs in 1 in 10 patients, from experienced centers, the odds ratio for stroke or systemic embolism was 4x. Now, the one piece of sort of good news from this paper was that in the 4 studies that measured peri-device leak by CT, there was not a significant association with future thromboembolism, though the confidence intervals were wide due to much smaller numbers. And it's the same with patency by CT scan. This was mentioned in 9 studies, and here the association with patency, which means non-occlusion of the appendage, was 1.45, or a 45% increase. So a 45% increase in future thromboembolic events. However, here the confidence intervals went from 0.85 to 2.5, so we would consider that not statistically significant. So my overall thoughts on this paper is that the word occlusion, my friends, the word occlusion is in the name of left atrial appendage occlusion. It's not LAAO for partial occlusion. Now, I can't help but think this discovery nearly 10 years after the seminal trials is one of the explanations for ischemic stroke rates being higher in the seminal trials. Like PROTECT and PREVAIL both had higher ischemic stroke rates in the Watchman arm versus warfarin. Now, of course, the other reason was the decision to stop oral anticoagulation after occlusion. Recall that one of the best studies in the entire cardiology space, the LAAO 3 trial, the surgical left atrial appendage occlusion at the time of cardiac surgery versus no occlusion, surgical left atrial appendage occlusion reduced stroke significantly compared with no occlusion, but oral anticoagulation in LAAO 3 was not discontinued. Now, why did LAAO 3 authors not stop oral anticoagulation after appendage closure? Because they said AF is a systemic disease and the appendage is only one source of stroke. Also, they said the entire evidence base of stroke and AF have shown the necessity of oral anticoagulation to reduce AFib-related stroke. Looking forward, I expect device iterations in percutaneous closure will reduce peri-device leaks. The devices will get better, but the human left atrial appendage is always going to be a tough hurdle due to its vast variability. And having a foreign body in the left atrium, blood pool will always be a challenge for just antiplatelet regimens. Also looking forward, I expect that as more studies report on CT scan patency, we'll likely see tightening of those confidence intervals and that 45% higher rate of thromboembolism in the 9 CT studies will likely become significant. I remain totally pessimistic about this preventive approach to stroke reduction, and I'm truly saddened by the fact that our field embraced this technique without proper studies. Think about it. Hundreds of thousands of these procedures have been done, and if only a fraction of these were enrolled in RCTs, we would know if this procedure provided a net benefit. Imagine, my friends, imagine if we were wrong about appendage closure. All right, next topic is about TAVI data strengthening the matter of stable coronary disease being a medical condition, not a surgical or procedural one. So I'm giving cardiology grand rounds today, Friday, at the University of Arizona, and my talk is on controversies in evidence-based cardiology. Of course it is. Part of my talk will focus on the stability of stable coronary disease and how this has mostly become a medical condition, not so much a condition requiring revascularization with bypass surgery or PCI. The European Heart Journal has published another nice study on post-TAVI results that strengthen this thesis. The question with TAVI patients who are generally pretty old and often have associated coronary disease is whether to do TAVI alone or TAVI along with PCI of the coronary disease. There are no clear recommendations, and the Cleveland Clinic authors, first author Ian Persitz, write that their group mostly takes a treat aortic stenosis first and then coronary disease only for symptoms. So the aim of their observational retrospective study was to assess the impact of varying degrees and extent of untreated chronic obstructive coronary disease on TAVI and longer-term outcomes. So this Cleveland Clinic group reported on about 1,900 patients who had TAVI at their center. They separated the groups into 4 categories: those with no coronary disease, those with intermediate, high risk, and extreme risk coronary disease, and they gave definitions for those. The outcomes of interest were all-cause mortality and complications, major adverse cardiac events, and post-TAVR unplanned coronary revascularization. Their findings are interesting. When they simply compared 2 groups, TAVI patients with coronary disease versus no coronary disease, they found that the incidence of MACE or death did not differ whether or not there was disease or not. Remember, these are untreated patients. Although patients with increasing coronary disease had higher rates of unplanned revascularization. Again, more revascularization, no difference in MACE or death. The overall rate of acute coronary syndrome was higher in those patients with obstructive disease compared with non-obstructive disease, but ACS, acute coronary syndrome rates, were not stepwise incrementally higher across the intermediate, high, and extreme risk coronary populations. And in multivariable analysis looking for associations between the extent of coronary disease and outcomes, the authors found no association between the extent of coronary disease and death or MACE. Not even extreme risk coronary disease correlated with MACE. The authors concluded that TAVI can be performed safely in patients with untreated coronary disease without a higher procedural risk and with relatively low rates of unplanned coronary revascularization or ACS at 1 year. Now, my comments. We should first point out that this is an observational retrospective study from 1 center. They also excluded patients from the analysis, 1,400 patients who had PCI or CABG before the TAVI. But the PCI patients, only 13% had the stent within 3 months before the procedure. Most of these cases were done for unstable angina. This sort of selection of patients leads to the possibility of bias in that a clinician, not randomization, chose not to do PCI before the TAVI. However, the authors do cite an RCT, one that I did not know about, called the Activation Trial, published in JACC Interventions, which studied pre-TAVI PCI to no PCI pre-TAVI. This was only 236 patients, and it was a non-inferiority trial. The rates of death or rehospitalization were similar, 41 versus 44%, although non-inferiority was not met. But death rates were similar, and bleeding rates were higher in the PCI arm. And in the as-treated analysis, which is a more rigorous test in non-inferiority trials, non-inferiority was met. I highlight this Cleveland Clinic observational study because it further supports the notion that stable coronary disease is quite stable. And revascularization did not reduce MACE, even in higher risk older patients, and even in the highest risk groups, which included those with multi-vessel coronary disease. And think about it, if this patient went for surgical AVR, they would surely have bypass surgery. The authors feel that treating the aortic stenosis first is the best strategy. The coronary disease can be treated medically, and revascularization can be reserved for symptomatic patients. Treating coronary disease medically and reserving revascularization is actually what the CASS authors concluded in 1983 after they found that CABG had no benefit over medical therapy in patients who had severe coronary disease. All right, third topic today is cardiac resynchronization therapy benefit over a long period of time. So let's do a word on CRT therapy. And specialists will know this topic, so I will keep it brief. CRT stands for cardiac resynchronization therapy. Another way we describe this is biventricular pacing. Now here comes the most important 4 words. It is electrical therapy. The problem with left bundle branch block is that the LV is activated later than the RV. The resulting dyssynchrony causes or worsens LV systolic function. Left bundle branch block in the setting of heart failure with reduced ejection fraction really makes things worse for these patients. A CRT device involves placing a lead into the LV branch of the coronary sinus to the posterior or lateral wall of the left ventricle. Then, once you have that lead, you can paste the RV and LV near simultaneously, and voila! The two ventricles now contract at the same time. The first time I heard this explained to me in the 1990s, I looked the pacer rep right in the eye and said that would never work. I can remember this like it was yesterday, down to the scrub sink I was standing at. Now, after oodles and oodles of trials, CRT is one of the most beautiful and established therapies for heart failure. It has made EP doctors into heart failure doctors. Anyways, let's move to the study. New England Journal of Medicine published long-term results of the RAFT, R-A-F-T trial. The original RAFT trial randomized about 1,800 patients with an ICD indication due to heart failure with reduced ejection fraction and a wide QRS to an ICD or a CRT ICD or CRTD. Most of these patients had New York Heart Association Class 2 heart failure. This paper included seriously long follow-up up to nearly 14 years. The original RAFT trial was published in New England Journal of Medicine in 2010, and in that trial, CRT reduced the primary outcome of death or heart failure hospitalizations over an ICD alone by a statistically significant 25%, and the absolute risk reduction was serious at about 7%. Death from any cause was also reduced by about 5% in the CRT ICD arm. This is a remarkable result, especially since patients with a wide QRS but not typical left bundle branch block were allowed in the trial. The most recent publication from the RAFT authors, first author John Sapp, studied patients in RAFT from the 8 highest enrolling centers in the trial. The main trial enrolled about 1,800 patients, and this long-term report involved about 1,000 of these patients. These were 67-year-old, mostly male patients with a mean ejection fraction of 22%. About 15% of these patients had AF, which is unusual for early CRT trials. 2/3 had ischemic cardiomyopathy, 1/3 non-ischemic cardiomyopathy, and the primary outcome of this analysis was just all-cause death. Remember, the first analysis, it was all-cause death plus heart failure hospitalizations, but over 14 years, it was, I think, the best they could do was to measure mortality. In the main trial, about 80% of these patients had either a left bundle branch block or RV paced rhythm, and I mention that because these are the patients most likely to improve with biventricular pacing. In other words, 20% of the patients in RAFT had QRS morphologies that associate with lower rates of CRT response. The results of this long-term study are pretty simple. Death occurred in 405 of the 530 patients. That's 76.4% assigned to the ICD group, and in 370 of the 520 patients, or 71% assigned to the CRT group. Pause there and consider these percentages of death, actually, not survival, death, 76% versus 71%. Only 1/3 of the patients were alive at the end of 14 years. The Kaplan-Meier curves are remarkable in that they go down to a very low survival rate, but they also stay separated for the entire time. The authors concluded the only obvious thing they can conclude, that CRT benefit was upheld over the long term. The Kaplan-Meier curves never came back together. Now, my comments. I highlight this trial for a number of reasons, not just because it was published in New England Journal. One was to commend the authors for recording and reporting on long-term results. And I don't mean this just as the blanket statement, good job, authors. I mean, long-term follow-up is really important in cardiology because most of our outcome trials go for only a few years. So we really don't know about long-term results. In this case, the robustness of the CRT effect was especially remarkable because 20% of patients in RAFT did not have the ideal QRS morphology. More than 90% of patients in this trial were already on ACE inhibitor and beta blocker, so the benefit of CRT was in addition to pretty good medical therapy of heart failure. Also, many patients in this trial crossed over from the ICD arm to the CRT arm, as well as over 14 years, there were certainly changes in heart failure management, and still the CRT benefit was upheld. One specific area that these results are especially helpful for is the generator change decision. Generator changes for battery depletions for an ICD or CRT are quite serious. Think about it. A, the patient is already 6 to 10 years older, which is more time to develop competing causes of morbidity and mortality. B, a gen change is harder surgery, and then you have to not damage the leads, and you have to get the new device to lie flat in the pocket, which requires some amount of surgery. And that is why I think the rates of hematoma and infection are higher after generator changes. And C, if there is an infection from a gen change, now the patient faces lead extraction of long-term scarred-in leads, which is quite a serious operation. Now, at least with this knowledge from RAP, this long-term data, we can feel better about doing CRT gen changes. So another reason to highlight the study is that at the end of 14 years, more than 70% of these quote-unquote mild heart failure patients had died. I was on a chat group of VP docs this week, and some expressed surprise that the death rate was so high. But I was not surprised. These were 67-year-old people. Remember, the average longevity of an American male is about 76 to 78 years. So another thing that this study reinforces to me is the need to think about and plan end-of-life care. One specific thing we can emphasize is the possibility of replacing the CRT-D with the CRT-P so as to avoid shocks at the end of life. Obviously, this is a preference-sensitive decision that must be aligned with patients' goals of care. But a good time to start this discussion is in the years, not weeks, before battery depletion. One last thing, and I'm talking here specifically to my EP colleagues. When you place a CRT-D devices in older patients, use a DF1, not DF4 lead, so changing to a CRT-P device is possible. All right, next topic is AFib monitoring after stroke. The Journal of the American Heart Association has published an observational study from Japanese authors who were interested in the risk of ischemic stroke recurrence in patients who had cryptogenic stroke with and without ILR-detected AF. That's implantable loop recorder detected AF. This study has got a fair amount of attention on Twitter or X, and the use of loop recorders after stroke is important because of cost and because of new data emerging on the definition of AFib. The retrospective study was done in 8 stroke centers in Japan. They looked at 370 patients whose clinician decided to implant a loop recorder after a cryptogenic stroke. AF was detected in 121 of these 371 patients, so about a third. And of these 121 patients, about half had AF burden less than 0.1%, and the other half had AF burden greater than 0.1%. The key finding was that only 17 patients had stroke recurrence, so all of the numbers I'm going to tell you are based on only 17 stroke events. Slightly more than 90% of patients who had AFib detected on their loop recorder were prescribed oral anticoagulation. So the incidence of ischemic stroke recurrence was about 4% in 249 patients without AF detection and 5.8% in the 121 patients with AF detection. The odds ratio was 1.47, so 47% higher is the point estimate. However, pay that no heed because the confidence intervals went from 0.54 to 3.95 and the p-value was 0.45, so not even close to significance, which would be 0.05. The authors concluded the risk of ischemic stroke recurrence in patients with cryptogenic stroke who had loop recorder detected AF, 90% of whom were subsequently anticoagulated, was not higher than in those without loop recorder detected AF. So my comments on the study. I have some biases, and my biases do align with the study findings. First of all, I do think that post-stroke loop recorders are massively overused. I also think the Artesia trial, which was apixaban versus aspirin in device-detected AF, and NOAA, edoxaban versus placebo in device-detected AF trials, these found that oral anticoagulation did reduce stroke events but increased major bleeding. These trials have tempted us to redefine AFib into separate categories of clinical AFib. Clinical AFib, that which is detected in a medical office on a 12-lead ECG, usually due to symptoms, versus subclinical AFib or device-detected AFib. I think these are different entities. The reason for the distinction now is that both Artesia and NOAA found extremely low annual stroke rates in patients who had short-duration subclinical AFib. The median duration of AFib in these trials was about 1 to 2 hours. So another relevant study that pertains to this paper is a sub-study of the LOOP trial. Now, LOOP trial was ILR, loop recorder screening for AFib versus no screening in high-risk adults. The authors of LOOP assessed the impact of prior stroke on the main trial findings, and this also sheds light on the use of loop recorders post-stroke. In this sub-study, which I discussed before and is published in JAMA Neurology in August of 2022, first author, my friend Soren Dietrichson, this team studied the effect of loop recorder screening in patients who had a prior history of stroke, which was about 17% of the patients in both arms, and they found interesting and potentially relevant findings. They found that in patients who had prior stroke, loop recorder screening, which picked up 3 times more AFib and resulted in more oral anticoagulation, did not reduce the primary endpoint of stroke and systemic embolism. But in patients without a prior stroke, loop screening did result in a statistically significant 48% reduction in stroke or systemic embolism. Pause there. Prior stroke, picking up AFib with a loop recorder did not reduce future events. No prior stroke, ILR screening increased detection of AFib and did reduce events. So let's put all of these papers together. We know that loop recorder reimbursement is massive, not just for the hospital due to the initial payments and DRGs, but also to the doctor and the system because patients get billed on a recurring basis either every 30 days or 90 days. There is an incredible financial incentive to do this quite easy procedure. We also know that the subclinical AFib RCTs, NOAA and Artesia, suggest that the type of AFib picked up on loop recorders, this short duration AFib, confers a very low risk of future stroke and no clear net benefit of oral anticoagulation. We also know from the LOOP sub-study, now this is just a subgroup finding, that patients with prior stroke may benefit less or not at all from loop screening. Taken together, therefore, all of these observations tempts me to love and promote the study from Japan. I could say, see, picking up AFib did not change the stroke risk, but the problem is that the study's methods are inadequate to conclude much. First, it's a retrospective study and likely to have selection bias. More importantly, though, there were only 17 stroke events and the 95% confidence intervals are so wide. This is not the methodology that should be used to sort out putative benefits from loop recorder monitoring after stroke. I laud the authors for collecting data. It's good, but it just isn't enough to answer the question. So I do wonder, though, maybe cooperative efforts among many centers with more patients might help sort out some of this signal to noise. But even so, observational methods here are always going to be limited because of selection biases. The proper method would be to randomize post-embolic stroke patients to ILR or no ILR, something like the Crystal AF study, but with outcomes not AF detection as an endpoint. And you might say, Mandrola, this can't be done. The event rates are too low. To this, I would say I disagree, and I feel like the device companies make enough money on these monitors to fund a 2-year study. And watch how fast enrollment would be if it was tied to reimbursement. Let me know what you think about these comments. I think we're really in the midst of a change in thinking about AFib and subclinical AFib. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, my friends, if you like this podcast, please take the time to give us a rating on whatever app you use. Write us a 1 or 2 sentence review. And of course, if you disagree with me, go to the web page, heart.org, Medscape Cardiology, leave a comment, and we'll do some listener feedback next week. Until next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.